Okay. Good evening, everyone, or morning, or afternoon, or that's anywhere you are in the world, anyway, that you are watching us from. So, this is our first live session. So, we want to talk about the osteology of the upper limb. So, what we are going to do is we'll talk about the osteology of the upper limb from the clavicle down to the phalanges. So it's going to be, let me say, comprehensive. And we are going to make use of our Blender 3D models, the 3D animation that we've built so far for this sole purpose. So that's exactly what we're going to be using. So this is our viewport. So that's the Blender, the 3D model of the skeletal system. So as you can see, I've unchecked all the other systems, the cardiovascular system, the muscular system, and every other system essentially. So just the muscular system. So I'm Dr. Latunji, and I'll be taking us through the osteology of the upper limb. So we can see we have two models of the skeletal system. So the reason why I'm using this one is because it's a bit faster, although less detailed, but this one is more detailed. But as you can see, the response is a bit lagging. So I guess because of the size, the memory. So generally, the upper limb is the most mobile limb between the upper limb and the lower limb. Of course, the lower limb is built more for support, to support our weight, while the upper limb is built for dexterity. So it is built in such a way as to assist us in performing our activities. In fact, it is what distinguishes us from other animals, our ability to use our hands to be able to manipulate tools. So we know that during evolution, so we begin to use tools for various purposes. So because of this, we developed with our upper limb developed into a major limb for us that we can be using. So now let's start properly. So generally, but before we know, we can just tell us where we are watching from. I want to know the demography of our followers. So just to know, so for our next live, we're able to know when to start the live. So we'll start from the bones that connect the upper limb to the body. That's the clavicle. So in essence, the upper limb sort of floats. You can see, let's start from the hands. So from the fingers, we have the phalanges and the metacarpals. And here we have our carpals. Those are the bones of the wrist. Then we have the radius, the ulna. Then up in the arm, we have the humerus. Then at the back, we have the scapula. But the scapula sort of is floating. Let me move it like this. We can see it's sort of floating. It's not directly connected to the body. So the connection between the scapula and the body is majorly by muscles. So at this point, there are certain muscles that attaches the scapula to the spine. One of them is the trapezius muscle, the traps. So it attaches the scapula to the backbone. So the scapula is not directly attached to the backbone. That connection to the trunk is done by the clavicle, and it's done at this joint over here. That's the sternoclavicular joint, this joint over here. So if we go to our second 3D model, as you can see, it's a bit laggy. So this is the sternoclavicular joint. So this here is the sternum. This is the manubrium of the sternum, and this highlighted bone, this is the manubrium of the sternum, and this is the clavicle. So this attachment is known as the clavicular joint, and this tiny joint is what connects the whole of upper limb to the trunk. This is in such a way that the upper limb will be freely mobile. In fact, the upper limb is so mobile that the shoulder is one of the most dislocated, in fact, it's the most dislocated joint in the body because it's very mobile. So it is freely mobile because of this tiny attachment to the trunk. So the only point at which the upper limb connects to the other part of the trunk is at this sternoclavicular joint. And so we have the clavicle, which attaches directly to the scapula at this joint known as the, so at this point of attachment, this is the medial head of the clavicle, which is a bit round. The lateral head is a bit flat, and it joins to the scapula at this point. So basically, the clavicle is also known as the collarbone. So it's tiny. What it does is majorly connection. It doesn't do much of movement. So a lot of bones attaches to this place, but most of them goes directly to the neck. One of the bones that connects here and affects the mobility of the upper limb are the pectoralis major, which attaches to this point of the clavicle, this at least the medial two third, and also the deltoid muscle also attaches to the lateral 1/3 of the clavicle. Then the trapezius muscle also connects to the clavicle. So those are the major muscles that affect the mobility of the upper limb that are attached to the clavicle: the pectoralis major, the deltoid, and the trapezius. So basically, the clavicle is majorly to support the upper limb, and it is one of the most common fractured bones. It's usually fractured when you fall on your outstretched arm, something they call fush injury. So they call it fush injury. So basically, that's the scapula, that's the clavicle. Then attaching to the clavicle, we have the scapula, which is roughly triangular shaped. It is a flat bone, as we can see. So let me bring it out. So we can see the scapula is essentially flat and is triangular shaped. So triangles generally have 3 sides and 3 angles. So the medial side, the lateral side, and the superior side. We also call it the medial border, the lateral border, and the superior border. So the junction between 2 borders are known as angles. Just as we know, a triangle has 3 sides and 3 angles. So we have a medial border, we have a lateral border, and a superior border. So the point at which the medial border meets with the lateral border is known as the inferior angle at this point, while the medial border and the superior border meets at the superior angle of the scapula, and the lateral border and the superior border meets at the lateral angle. The lateral angle is adapted to form what is known as the glenoid cavity, as you can see. So we can see this is the lateral border. So looking at it from the lateral aspect, we can see this depression is known as the glenoid cavity. And what it does is it articulates with the head of the humerus. So if I bring it back to connect to the humerus, we can see. So we can see this is the humerus. This is the head of the humerus attaching to the glenoid cavity. There's a knuckle-like projection just above the glenoid cavity. This knuckle-like projection, you can see, is looking like a knuckle. Is known as the acromion, the coracoid process. It's known as the coracoid process. So that's the coracoid process of the scapula. So if we go to this more detailed anatomical model, we can see this is the scapula. This is the coracoid process. We can see it is labeled. So this is the coracoid process. Now, At the posterior surface of the scapula, there's a spine, there's a ridge which divides it. So this ridge is known as the spine of the scapula. The spine of the scapula. So this spine of the scapula divides the posterior surface into the supraglenoid fossa, which is here, this depression here. And it is the point of attachment of the supraspinatus, that is above the spine of the scapula. So this area is known as the supraspinous fossa, and the muscle known as supraspinatus muscle originates from this area. Now, inferior to that spine, we have the infraspinous fossa, and as you can guess, the infraspinous fossa is the point of origin of the infraspinatus muscle. So the spine of the scapula continues outwardly or laterally and becomes a projection that is known as the acromion process. So as we can see, this is the acromion process. This acromion process directly lies above the shoulder joint. So as you can see, this is the glenoid cavity, this is the head of the humerus, and this is the acromion process. Is above the shoulder joint. Now, this bony structure above the shoulder joint, that is the acromion process, if there's a force trying to push this humerus, for example, upwards, let's go back to the low detailed. So if there's a force trying to push this bone upward, we'll see that there will be a sort of resistance at this point, which means upward or superior dislocation of the shoulder is not as common as inferior dislocation. The reason is there's no bony structure protecting this inferior end of the shoulder joint. So it is very easy for shoulder joints to dislocate inferiorly. In fact, the most common dislocation happens anterior inferiorly, that is, it happens forward and downward. That's the most common dislocation of the shoulder joint. So this bony prominence that lies above the glenoid cavity is known as the acromion process. So there's a coracoid process, there's the acromion process, then the anterior surface of the scapula. The anterior surface of the scapula is the point of origin of the subscapularis muscle. So let me ask a question. This knuckle-like projection, that is the coracoid process of the scapula, there are some muscles that originate or that attaches to this point. There are three muscles generally: the pectoralis minor, the coracobrachialis, from the name coracoid, from the coracobrachialis. So, and then also the short head of biceps brachii also attaches to that point on the scapula. So next we have the humerus. So this is the longest bone in the upper limb. The humerus is the longest bone in the upper limb. It is the longest bone in the upper limb, and is one of the longest bone. It is one of the long bones in the body. It is very strong. Sorry, few minutes. Okay, so we have the humerus, which is the longest bone in the upper limb, and is one of the long bones in the body. So it's one of the long bones in the body. So the humerus has the proximal end, which is at this point. Then there's the shaft, and then we have the distal end of the humerus. So as we can see, the proximal end, if we zoom in to the proximal end of the humerus, so the proximal end of the humerus is adapted into the head. This ball-shaped structure is the head of the humerus. Now, the glenoid cavity is shallower than the head of the humerus. The head of the humerus is about 4 times as big as the glenoid cavity. So the support from this from this rim of the glenoid cavity to the attachment point of the head is usually done by ligaments. So it's usually done by ligaments, and this point of attachment where those ligaments of that joint attaches to is known as the neck of the humerus. That's the anatomical neck of the humerus. That's the attachment point of the capsules of the shoulder joint. So after the anatomical neck, there are 2 prominences: the greater tubercle and the lesser tubercle. So the lesser tubercle is more lateral, and the lesser tubercle projects anteriorly. So if we go to the side view, let's go to the side view of the structure. So we can see this is the greater tubercle, which points laterally, and the lesser tubercle points anteriorly. There are some important muscles which attaches to the greater tubercle and the lesser tubercle. Then in between this tubercle, we have what is known as the intertubercular sulcus. Intertubercular sulcus. So let me zoom it out and we can see. So this depression in between the tubercle is known as the intertubercular sulcus. All right, sorry, give me a few minutes. I'm having issue with this network. Let me sort it out. 768 kilobytes per second. That's okay. It's still not improving. So we have the intertubercular sulcus in between the tubercle, and at the intertubercular sulcus we have the long head of biceps. So the long head of biceps brachii actually passes through this intertubercular sulcus. Now just at the end of the tubercles, we have the surgical neck of the humerus. Remember, the anatomical neck is the point of attachment of the joint capsules of the shoulder joint. Now the surgical neck, which happens here, this area just beneath the tubercles, the surgical neck, because it is the most common fractured commonly fractured area of the humerus. So it's the most commonly fractured area of the humerus. So it is known as the as the surgical neck of the humerus. So if we go downward from there, we have the shaft of the humerus. We have the shaft. Sorry, I'm coming. All right, so sorry for that. So the surgical neck, which is the most commonly fractured area of the humerus, then from there we have the shaft of the humerus. So the humerus roughly is cylindrical in cross section. So as you can see, this middle portion from the surgical neck up to this point is known as the is known as the shaft of the humerus. It's known as the shaft of the humerus. So if we go posteriorly, if we go to the back on this shaft, there's usually a groove on this posterior end. It is known as the radial groove. So we can see it is actually labeled, although not well illustrated. But here we have the radial groove. We have the radial groove. So it is the point where the radial nerve passes through. So the radial nerve passes through. So if there's a shaft, if there's a fracture of the shaft of the humerus, it can cause injury to the radial nerve, leading to a condition called wrist drop. So, but we talked about the surgical neck being the most commonly fractured area at the neck. Now, if there's a fracture at this point, there is injury to the axillary nerve. But if there is a fracture of the shaft, there is injury to the radial nerve. At the distal end of the humerus, we have many important bony prominences. So if we go to the distal end, so we have two projections known as the epicondyles. So we have the lateral and medial epicondyle. So this point is the lateral epicondyle of the humerus, while this point is the medial epicondyle. So the medial epicondyle is more prominent than the lateral epicondyle. Then the condyles are adapted to, on the lateral side, the capitulum, and on the medial side, we have the trochlea. So above the trochlea, there's the radial fossa. Above the trochlea, there's the coronoid fossa. So the coronoid fossa accommodates the coronoid process of the ulna. Now, if we've not talked about the ulna, yes, we are coming to it, but if we see this projection on the ulna, this projection here is known as the coronoid process. So during flexion, the coronoid process fits into the coronoid fossa of the humerus, and likewise the head of the radius fits into the radial fossa, which is just above the capitulum of the humerus. So in the forearm, we have two bones which run parallel to each other. We have the radius and the ulna. So the ulna is on the medial side, while the radius is on the lateral side. So the radius is shorter than the ulna, but the two bones are kind of opposite. So if we look, we see that the ulna is bigger at the proximal end and get thin as it moves distally. But if we look at the radius, the proximal end of the radius is a little bit thinner, is thinner than the distal end. And another difference is that the head of the ulna is at the distal end. This point is known as the head of the ulna, this point, while the head of radius is at the proximal end. This place is the head of the radius. So they are kind of opposite in the forearm. So the ulna and the radius. So if we move the ulna, let's go to the lower resolution images. So as we can see, this is the ulna. So if we move the ulna and we try to isolate it, now this we said this point is the coronoid process of the ulna. If we go to the posterior side, this projection is known as the olecranon process of the ulna. This projection is the olecranon process of the ulna. On the posterior surface of the humerus, if we go to the posterior surface of the humerus, there's a projection. Let's go to the high resolution image. There's a projection on the posterior surface of the humerus. This projection, this depression, this is known as the olecranon fossa on the humerus. So the distal end of the humerus has three fossa: the coronoid fossa, the radial fossa on the anterior side, and we have the olecranon fossa on the posterior side. So this olecranon fossa accommodates the olecranon process of the ulna during elbow extension. Basically, that's the proximal end of the ulna, and then it thins out distally to form the head ulna. Now, just on the medial side of the head, we have the styloid process. So this little projection is the styloid process, of the ulna. The radius, the head of the radius, unlike the ulna, is at the proximal end. So there is the head of the radius at this point, which articulates with the capitulum of the humerus. And then as we move from the head, it narrows. This narrow portion is known as the neck of the radius. And then just below the neck, we have the radial tuberosity. So the radial tuberosity is the point of attachment for the biceps brachii muscle, which helps in supination of the arm, of the forearm. So the radius, we have the shaft, and then we have the distal end of the radius, and on the lateral side we have the radial styloid process. So this is the radial styloid process. The ulnar styloid process is on the medial side. So those are the two bones of the forearm. Then if we go to the distal end of radius usually fractures. Now there are when especially young children, when they fall on outstretched arm, this distal portion, the junction between this proximal two-third and the distal two-third of the radius usually fractures. So depending on the displacement of the distal fragment, it can either be a Colles fracture or a Smith fracture. Then just below the radius and ulna, we have the carpal bones, the 8 carpal bones. So let's go to the lower resolution image. Let's move our ulna back to its neutral position or the anatomical position. So we have the 8 carpal bones. So let me bring them out. So we have 1, the 2nd, 3rd, 4th and 5th, 6th, 7th, and the 8th. So if we bring them out, these are the 8 carpal bones, and they are arranged in 2 rows. So we have the proximal row 1, 2, 3, 4. So basically we have the scaphoid, we have the lunate. So the scaphoid and lunate, they attach to the so let's bring them back to their neutral position. So you can see the scaphoid and lunate, they articulate with the distal end of radius. So that is what forms the radiocarpal joint. The ulna does not articulate directly with the carpal bones. So the radius articulates with the scaphoid and the lunate. Then we have the triquetrum, which on the anterior surface you can see this tiny bone. This is known as the pisiform. So the pisiform is a sesamoid bone. So those 4 bones complete the proximal row. So if we go to the high resolution image, so we can see the scaphoid, the lunate. So we can see the scaphoid, the lunate, the triquetrum, and then the pisiform. So the pisiform is a sesamoid bone, and it is located in the tendon of the flexor carpi ulnaris muscle. Then in the distal end of the wrist, we have another 4 rows. So we have the trapezium, then we have the trapezoid, then we have the capitate, which is the largest of the carpal bones, and then we have the armate. So the armate actually has if we go to this low resolution image, you can see the armate, there's a hook like projection. There's a hook in front, also known as the hamulus. So this serves as attachment point for muscles, for tendons of muscles, especially the flexor carpi ulnaris tendon. So if we move them back to their natural position, so we can see. So these are the 4 bones of the distal row: the trapezium, the trapezoid, capitate, armate. Then in the proximal row, we have the scaphoid, the lunate, the capitate, and the the scaphoid, the lunate, the triquetrum, and the pisiform. There's a mnemonic people use to remember these carpal bones. So you can just use this mnemonic: some lovers try positions that they can't undo. So if you can use that mnemonic, so some lovers try positions that they can't undo. So the S is for the scaphoid, the L is for the lunate, that's lovers, tri, that's the triquetrum, positions for pisiform. Then we have the some lovers try positions that, so the that is for the trapezium, they, that will be the trapezoid, the cant will be the capitate, and the handle will be the hamulus. The hamulus has a handle, the hook-like handle that we mentioned about the other time. So after the carpal bones, we have the metacarpals. So we have 5 metacarpals. So we usually number them from the outer side to the inner side. So we have the first metacarpal, second metacarpal, third metacarpal, fourth metacarpal, and the fifth metacarpal. So these 5 bones forms the bony framework of the palm. So if we go to the high resolution image, we can see. So we have the first metacarpal, the second metacarpal, the third, the fourth, and the fifth metacarpal. And each of these metacarpal actually has a head, a shaft, and a base. So these 5 bones generally forms the framework of the palm. And then the fingers, we have the phalanges. We have 14 phalanges in total. So we have now the apart from the thumb, the other fingers have 3 phalanges. So we have the proximal phalanges. So we have the proximal phalange of the second finger. This is the proximal phalange of the third finger. This is the proximal phalange of the fourth finger. And this is the proximal phalange of the fifth finger. Then this is the proximal phalange of the thumb or the first finger. Now we can see that the second finger to the fifth finger has a middle phalange. So as we can see, if we zoom in on these fingers, so we can see this is the first proximal phalange, the second proximal phalange, the third, fourth, and fifth. So from the second to the fourth to the fifth, we also have the middle phalanx. So we have the middle phalanx of the second finger, middle phalanx of the third finger, middle phalanx of the fourth and the fifth. But the thumb does not have a middle phalanx. That's why the thumb is, of course, shorter than the other fingers. Even the pinky, if your arm in anatomical position, even the pinky is longer than the thumb. So then we have the distal phalanx. So the distal phalanx of the thumb, the distal phalanx of the second, third, fourth, and the fifth metacarpal or the fifth finger. So basically, those are the bony frameworks of the upper limb. So generally, we have 14 phalanges, the 5 metacarpals, the 8 carpals. So that will be 14 plus 5. So that will be 19. So 19 plus 8, that will give us 27. 27 plus the 2 bones in the forearm. So that will give us, okay, we calculated 27. So that will be 29. Then we have 28. No, we have 30. So we have like, no, let's count again. So we have the 14 phalanges of the fingers. So we have 3 for the second, third, fourth, and fifth. So that makes 12. Then 13, 14. So 14, we have 5 metacarpals. So that makes 19. So if we add that to the 8 carpal bones, remember, some lovers try positions that they can't undo for scaphoid, lunate, the triquetrum, the pisiform, the trapezium, the trapezoid, the capitate, and the hamate. So that would be 19 plus 8, that would be 27. So plus the radius and ulna, that would be 29, plus the humerus, that would be 30, plus the clavicle and scapula, that will be 32. So we can say that we have 32 bones in the upper limb. And we have how many joints? So let's count. So if we start from the phalanges, so the junction between the distal and the middle phalanges is known as the distal interphalangeal joint. We are talking about in between phalanges. So the distal interphalangeal joint. Then the one between the middle and the proximal is known as the proximal interphalangeal joint. Then between the metacarpals and the phalanges, we have the metacarpophalangeal joint. Then in between the carpals and the metacarpal bones, we have the carpometacarpal joint. The first carpometacarpal joint is actually a saddle joint. So the first carpometacarpal joint is a saddle joint. Then the joints in between the carpal bones in itself, they are actually condyloid joints. Then between the radius and the scaphoid and lunate is an example of a condyloid joint. Then the elbow, we have a hinge kind of joint in the elbow. Then the shoulder joint is an example of a ball and socket joint, which allows motions in all directions. So in essence, that's the summary of the osteology of the upper limb. So basically, that's the summary of the osteology of the upper limb. So we have 206 bones in total, and we've covered 30 bones. We've summarized 30 bones. So you can, I think, with this life, by the time you are reading your anatomy, if you are reading the osteology of the upper limb, it's going to be much easier. It's going to be much easier, and it's going to be much more enjoyable. So at least I've given, so we can go over some clinical correlates that we've mentioned about. So we have the clavicle, which is the clavicle is a long bone anyway. The clavicle is a long bone. So it has, if we look at it, the medial end, just like we mentioned, is rounded in cross section, but the lateral third is flattened. So is commonly fractured during childbirth in children, and in young children, it can fracture. There's a type of fracture it undergoes. We call it green stick fracture. That is, it didn't break completely, but it sort of bends. We've made a video on types of fractures before. We talked about compound fracture, open fracture, closed fracture, green stick fracture, comminuted fracture. You can go ahead and check out the video on ABC tutorial. So just search for the types of fracture, so you see the different types of fracture. We've talked about it. So the clavicle is an example of a bone that commonly undergoes green stick fracture. Then we talked about the clavicle being the major bone that suspends all the upper limb from the trunk. So this tiny joint here, the sternoclavicular joint, is the point of attachment of the upper limb to the trunk. All the other attachment points are provided by muscles. For example, the pectoralis major, that's our big chest muscle. The big chest muscle, the pectoralis major, connects this medial two-thirds of the clavicle, the sternum itself, even to the costal cartilages. It originates from all those areas. Then it inserts into the humerus along the ridge of the lesser tubercle. So the pectoralis major attaches the humerus indirectly to the trunk, even though there is no bony connection from the humerus to the trunk. But those muscles, those big muscles, provide the attachment. The same thing goes at the back. So the trapezius muscle, which originates from the base of the skull here, it also, there's a nuchal ligament here. It originates from it. Then the spinous processes of C7 to T12, it originates from there. Then it inserts into the spine of the scapula, the acromion, and into the clavicle. So it sort of attaches these bones to the trunk. So even though there's no bony connection between the scapula, the humerus, and the trunk. Those big muscles actually, those big muscles, they do so. So the joint is mobile, but at the same time the joint is stable. So it's a sort of evolutionary advantage for humans. So the those big muscles provide support, but at the same time it provides mobility. So we can move our hands, we can reach various areas, we can modify tools, we can do a lot with the hands while still being strong, not very rigid. So it's not rigid, but at the same time it is suspended by big muscles. So all right, so